Good morning, everyone, and welcome to today's QI Power Hour session. This is Gary Tier, CEO of the Health Quality Council here in Saskatchewan. Those of you who are joining us for the first time, QI Power Hour is a free monthly WebEx offering that's hosted by the Saskatchewan Health Quality Council. QI Power Hour provides opportunity for colleagues across the healthcare system, as well as from other industries, to hear from local and national improvement experts on a variety of quality improvement related topics. So we're glad that you've joined us. Just a reminder that these sessions are recorded and posted to Health Quality Council's website, which you can see the link will be sent around or will be available. It's basically hqc.sk.ca and then go to News and Events, QI Power Hour. So session is recorded so that our colleagues who aren't able to join us on the webinar today can catch it later. So because we're also using a teleconference line in conjunction with our webinar today, please note that we require all participants to mute their lines. So please don't use the mute function on your local phone, but rather press *6 to mute your line. Sometimes when people use the local mute function, it makes music play through, and that's lovely to hear, but we'd rather hear our speakers. Again, at the end of the session, when we come to the Q&A part, you can hit *6 again to unmute your line if you'd like to speak. So I'll just give everyone a moment now to make sure their lines are muted by hitting *6. Okay, so these sessions are designed to be fun, interactive learning sessions. So we really encourage your participation on today's webinar. And importantly, we encourage you to use the chat function during today's session to share your questions, comments, and ideas. And just do that as the presentation rolls, because we'll collect up those questions and try to give an opportunity to address those at the end. But also, people just like to see the interaction and what people are learning or what's standing out.
People love it, Jeff. They love it.
Okay. So just make sure you hit *6 on your phone to mute your lines. You'll find the chat function on the upper right-hand side of your screen, and you can access the chat function by clicking on the message bubble on the top right-hand side of your screen. That's that little thing that looks like a cartoon dialogue bubble there. We encourage you to share your questions, comments, and ideas throughout the presentation. We'll have some time dedicated to Q&A at the end of the presentation and welcome you at that time to pose your questions either through the teleconference line or through the chat if you haven't already shared them during the presentation. Please, when you send your questions or comments, direct them to all participants, and that way everyone can join in the discussion. If you happen to experience technical difficulties, like you can't hear the speaker or something like that, use the chat messaging, but please just direct the message to the HQC host, and we're happy to work with you to resolve the issue. So let's just take a moment right now to practice this chat function by having each participant type into the chat the name of the organization from which you're joining us today. So we'll take a moment to do that. Just use the chat, type in what organization you're dialing in from or calling in from. Great, so I see Cyprus Health Region, Ministry of Advanced Education, eHealth, Health Quality Council, Saskatchewan Health Region, or maybe that's Sunrise, I'm not sure what SHR is. Sun Country, more Ministry of Health, more Saskatchewan Health Region. Great. Keep them coming. We'll look forward to that. That also helps us understand who all is listening in and what the reach of the program is, which is an important way of evaluating the impact. Also, if you happen to be a tweeter, we encourage you to use Twitter as you listen to today's session and share your learnings. So use the hashtag QI Power Hour and the handle HQCSask. So in these webinars, we typically have representation from all of our 13 health regions attending. We've also seen participation from other healthcare agencies as well as organizations that aren't in healthcare within Saskatchewan that have an interest in quality improvement. And so we welcome the participation of all and really thank you for picking this up and hope that these are really of value to you as you listen in, and look forward to your comments and questions. We've also begun to see some spread to other organizations within Canada and beyond, and look forward potentially today for Jennifer Graham from Health Improvement Scotland to join. We've got a growing relationship with them and the wonderful webinar series they produce called QI Connect. So without further ado, I'm now delighted to introduce the topic and the speakers for today, health system modeling for strategic planning to reduce emergency department wait times. And I'm delighted in that vein to introduce Adrienne and Yuan, who will present on that topic. Now, Adrienne has worked in the Health Quality Council since 2010 in various roles and on various projects. She's got experience in building measurement capacity across the health system, as well as building measurement systems to support provincial quality improvement initiatives. Her current role is with the Emergency Department Wait and Patient Flow Initiative, where she works with a team to implement evidence-informed strategies to improve patient flow and reduce waiting in emergency departments throughout Saskatchewan. And Yuan is a researcher at HQC, at Health Quality Council here. She's extensive experience in developing computer simulation models for many health and healthcare-related problems, including stroke care, tuberculosis prevention, seniors care, lung cancer screening, and patient flow. The insights from computer simulation modeling have many applications to healthcare policy and interventions. And over the last 2 years, Yuan has supported the provincial ED waits, emergency department waits, and patient flow initiative to better understand the root causes of waiting time in emergency departments and in hospitals. So the simulation models Yuan builds are built using local and health system data, research evidence from the research literature, as well as stakeholder expertise. And she has deep experience with this and is somewhere in the middle of getting her PhD in health simulation modeling and its applications in healthcare. So without further ado, I'll turn it over to our distinguished speakers.
Thank you, Gary, for the introduction. So at the beginning of my presentation, our presentation, the first question I want to ask is, I think you might be curious, is what is simulation modeling? So I made the assumption that many of you are unfamiliar with simulation models. I will start with several real-world applications in modeling and simulation. Number one, live simulation games. And many of us do play games. So some of the games are actually simulation. In some ways, for instance, like this game, it gives you virtual life to explore the virtual world. And another example is the rocket launcher simulator. So in engineering, it is very common to use the simulation as a tool to test the rocket launch prior to the official launch so that they can understand under all kinds of conditions what is the risk of failure. So for the final ones, they can make sure the success chance is very high. And a third example will be flight simulator. So if you want to be a pilot, I think a flight simulator could be a really good start. You actually can learn by using flight simulator. You also can make mistakes without experiencing any real risk of crashing. And for the fourth example I want to give to you is the spread of zombie disease outbreaks. So this is actually a simulation done by a group of researchers from Cornell University, and they use this simulation trying to understand the outbreak of infectious disease, and so that they can run a lot of what-if scenarios on, say, vaccination and policies or interventions can stop the spread of infectious disease. And basically, there are a lot of real-world applications in modeling and simulation. I think one idea I do want to share it is, so you might not be aware, you actually are exposed to quite a lot of application of simulation modeling. I hope this gives you a kind of a first a taste of what is simulation modeling is, and then let's move on to what is simulation modeling. So if we look at the definition, so simulation modeling is the process of creating and analyzing a prototype of a physical model to predict its performance in the real world. First of all, simulation modeling is not a breaking news. It's in the healthcare industry, basically, it is a little bit late to the party. It is not a new technology. It has been used in other industry for 30, almost 40 years now. But like many other IT advancements, healthcare lags way behind. So there's so much can be done. And there are well-established methodologies to analyze inefficiencies in healthcare system processes. So, for instance, there's 3 methodology I listed here as examples. Number 1, discrete event simulation. This is also the tools that we use to develop our simulation model in Saskatchewan context. You also see application of simulation modeling using agent-based model as well as system dynamics. And you can develop and use simulation models to design, evaluate solutions that will improve quality of care, patient flow, patient safety, and cost effectiveness in healthcare. So in healthcare, most operational changes are made on the basis of expert opinions. I think most of us will agree that in those cases, it will be very helpful to have a way or means to test whether a change in operation or process will work before investing money, time, effort. And it is very expensive to go to the wrong path. Simulation model can help you just do that. And it is generally more efficient to simulate large scale of clinical processes on a computer rather than the real world. You can control all the variables, have all the space you need, virtually speaking. You can quantify the effects of bottleneck and determine what needs to change and by how much to change to achieve a particular objective. And then we say here, this graph shows you, say, why we use computer simulation model. And this is actually the rationale for us to use the computer simulation model in the Saskatchewan context. So for instance, if you consider how to assess a change in your clinical operation or think of doing healthcare planning in your department or branch, and traditionally you have experimented with the actual system by running the real pilots. And new models of care, particularly those that differ significantly from existing ones, can be risky to implement. You might look for evidence of similar models working elsewhere, but these are not always forthcoming. If you do find examples, they might not be directly applicable to your own setting, particularly when the model is novel. Pilot projects to test out new services can be costly, disruptive, time-consuming, and many not reveal the real impact of the service on the rest of the healthcare economy. So modeling the new service and simulating its operation is one approach you should consider in order to gain understanding of its performance and impact on other parts of the healthcare system. So in short, we understand the pilots in the real world are complicated. If you try something and fail, the cost and the failure of the experiments are long-lasting. You might encounter resistance when you plan to try something else. Perhaps it is wise to start with experiments using computer simulation model, like you are trying to do a virtual pilot, and which give you better information about how likely it will succeed and how long does it take to reach your expected outcomes. And this is, I think, the rationale for us to use this tool. And so in the next 20 minutes, we will demonstrate a case study, use simulation model for strategic planning to reduce emergency department wait times. So now I will hand it to Adri, which will give you, she will give you some background about emergency department wait time in Saskatchewan, and we will walk through the background of this problem as well as how we use simulation model trying to better understand the cause of ED crowding. Yeah.
Perfect. Thanks, Yuan. So this is Adrian, and in the next few minutes, I plan to answer these 5 questions that you see here on the slides, just to really set some context around the work around emergency department waits, why it's important, why should we care, what is crowding, and how we use modeling to help set some strategies going forward. So ED crowding is a national and international problem and is quite commonplace in many centers. And we know overcrowding is an obvious concern for people who are working in the emergency departments, but it truly is a health system issue. ED crowding is a measure of health system performance, and the monitoring of overcrowding should really be part of the focus on measurement of the quality of health care. ED waits are really the canary in the coal mine as far as challenges in the system. So the Canadian Association of Emergency Physicians define ED crowding as a situation in which demand for service exceeds the ability to provide care within a reasonable time, causing physicians and nurses to be unable to provide quality care. So we can measure ED crowding by measuring wait time, time to see the physician, time to see a consultant, and the time it takes to move through to an inpatient bed. There is lots of evidence about the negative impacts associated with extended waits in the emergency department. So this is obviously why it's important to focus in this area. Long waits in the ED has shown increase in deaths, costs, longer length of stay in hospitals, and in being able to provide timely care to patients who need care very quickly for those folks who have very time-sensitive conditions. And of course, decreasing patient satisfaction, because we all really hate waiting. So I'm going to take a few minutes to dive into a few wait time measures, the ones that we're particularly focused on here in Saskatchewan. So let's take a patient perspective for a minute here. Let's say you need to go to the emergency department. You start by getting registered and triaged, which means you're being assessed for the level of urgency of care that you need. After that, you'll see the physician and your care will start. So at some point, the physician will either decide to admit you to the hospital or discharge you home from the emergency department. If the decision is made that you need to be admitted into the hospital, at some point, you'll leave the emergency department and move up to a bed on a ward or a unit in the hospital. If it's determined that you can be safely discharged home, the time between when you're registered and the decision to discharge is your total ED length of stay. So that's for non-admitted patients. If it's determined that you need to move up to the hospital, then your total ED length of stay is from when you're registered until when you're actually in that inpatient ward. Two key measures in the emergency department that the patient flow team is looking at is the time between when you register and when a physician actually sees you for the first time. That's the Wait for Physician Initial Assessment, or WPIA. The other measure that is important is for those patients who are being admitted to the hospital, and that's the time between the decision to admit and the time when they are on another unit within the hospital. That's the time waiting for an inpatient bed. We often refer to it as TWIB. So if we want to reduce those wait times, what should we do about it? If we think about flow, we've all had some examples of flow where we've gone through a drive-through, for example. There's an input where you're driving into the drive-through. There's a throughput for when you put your order in, for example. There's the output when you pick up your order and then continue on through the drive-through. So similarly, there's these three stages of flow through the emergency department. And if you take, so then within each of those areas, there's opportunities for improvement. And these are just a few examples of what I'm going to present here. People in the emergency department.
The conference is in lecture mode.
So if you think about people coming into the emergency department, there are potentially some inappropriate inputs into that. So one example is the ED visits with family practice sensitive conditions, and this is actually a specific definition for cases like sore throat, cough and cold, eye or ear infections, people who are coming into the emergency department with those types of conditions that could be better managed with at a family practice office, for example. Another potential source of potentially inappropriate inputs into the emergency department is this hospitalization for ambulatory care sensitive conditions. So because we like acronyms, ACSC, ambulatory care sensitive conditions, is actually a set of 6 chronic conditions. And for folks who are less than 75 years old, hospitalization for those cases is considered inappropriate. And those chronic conditions are diabetes, congestive heart failure, COPD, coronary artery disease, hypertension, and mood disorders. So these are potential areas for inappropriate visits into the ED. Another input is around continuity of care with family physicians. So are people accessing the emergency department because they don't have access to their own family physician, or they find it difficult to be able to access their family physician of choice? Within throughput scheduling, so this is within the emergency department itself, there may be opportunities for improvement as well. So do we have the right staff scheduling mix of physicians, of nurses, of consultants, et cetera? Also looking at the ED resources and capacity, so diagnostic imaging, lab tests, the time to see other specialist consultants, for example. There's opportunities to improve flow through the emergency department by looking at throughput specifically. Likewise in output. So if you think of those patients who are being admitted to a hospital bed outside of the emergency department, there's potential challenges in those beds being already occupied with patients who we term ALC, and this stands for alternate level of care, which really means patients who are occupying a hospital bed but no longer need that intensity of service. And so that can cause some challenges for those patients who are in emergency department and waiting to get up into a unit bed, but that unit bed is not available because there are ALC patients occupying those beds. The other thing to consider around output is potential lack of coordinated care in the transition from hospital to home. And this is something that we've termed high-quality care transitions, and it's really how well are we coordinating things like discharge planning, medication management, communication back to community services within that patient's home area. So there's lots of potential places for improvement, and we still face the question of what are the root causes of long wait times in Saskatchewan hospitals specifically. And given that we have limited resources, where should we act first, given that we need to be really thoughtful about doing some of this work? So given these operational barriers, is there a systematic way to organize our knowledge, combine our insights, and to develop some solutions? And what the patient flow team has used is a process called cross-functional planning. As you've seen, ED waits is really a system issue, and our system in Saskatchewan is very complex. What we've presented so far is even relatively simple. When you add on the layers of 13 health regions, various service lines, branches of the ministry, all impacting parts of this continuum, we all are doing really great work, but it often happens in silos. And so cross-functional planning is a framework and a structure that is about planning seamlessly across various organizations, regions, service line, and branches of the health system from the perspective of the patient and family. So we often refer to the framework for cross-functional planning as a triangle. One of the elements is data. So this is our local health system data that helps us identify our current state, gaps, and opportunities. Another corner of the triangle is evidence, and Yuan spoke to this a little bit. We use literature from around the world to feed into the model, so we know what's happening and what is truly evidence-based information and potential sources. And of course, we need to use the expertise within our stakeholder group to be able to give us local context and understanding. To a certain extent, make sense of the data by talking with people about what's happening really on the ground. So we put all these pieces together through the health system model, and it outputs or helps us output and develop some recommendations for future planning and budgeting and moving forward in order to thoughtfully address the challenges in the emergency department. So I'll turn it back to Yuan. She's going to talk a little bit more about the patient flow model in Saskatchewan, what it is, how it works, and what it told us. Thank you, Adri. And so in this slide, you actually can see a visualization of the healthcare system model that we developed for the patient flow. So on the left side, we do have a population module, and which actually give you a Saskatchewan population projection by age and gender. So going forward, so if we have an aging and growing population, what will be the potential impact on ED rates given the possible increase in ED volume. And on the right side, you actually see a demo of emergency department in Royal University Hospital. This should be this is actually a 3D visualization of the Royal University Hospital. So we use the visualization really trying to build our trust with the stakeholders and with other experts. So in a way, we make sure we model the right process in the emergency department. And so there's a lot of equations as well as theories we actually use trying to build this model. So I kind of hide all the mathematical equations, without make you feel overwhelmed. So regarding the model structure, so we actually simulate the patient flow in emergency department, in acute care, as well as some proportion in long-term care facility. So on the left side, you probably won't see the details of it. Basically, we lay out what the structure of the model, what the assumptions made for each of the model inputs, what data source we use. We use HQC administrative data a lot, like NACRS, that's trying to populate the model with the best kind of understanding of the current state. On the left side of that figure is actually all the assumptions we made in the model. We understand that all models are wrong, some are useful, so we really want to communicate about the assumption we made in the model, because sometimes if we made a different assumption, the model behavior might be different. We understand there's definitely uncertainty within those models. And so we built this patient flow model in ED acute care for 6 hospitals in Saskatchewan. And we built patient flow model for Regina General Hospital and the Pasqua Hospital in Regina, Saskatoon City Hospital, St. Paul Hospital, and the Royal University Hospital in Saskatoon, and the Victoria Hospital in Prince Albert. So each hospital will have its own patient flow model integrated with its own data. So every hospital will be modeled separately and differently. And then, say once we have the data, and so we know the current state, so we're trying to use this powerful tool to build a model, how we can trust the model. So to adjust, in order to answer that question, we have done a lot of work on model calibration and validation. So first of all, we have an internal validation. So we build a model with the use of a lot of data provided by the region, with the data, with evidence, with assumptions. And one way we can do that is trying to compare whether the model behaves similar to what we observe in the historical data. So this table just shows you how the model outcome is different than what we observe in the historical data. You might find they are very closely matched. We understand there's randomness within the model, so there will be some small discrepancy, but overall speaking, I think the model matched with historical data pretty well on both two weight measures. And then beyond the internal validation, we also did an external validation. For the external validation, we had a meeting last September, and really trying to open the black box of the model to a group of experts familiar with health system data or health system modeling, trying to get feedback, suggestions, and critiques on inputs into the model, methodologies used, assumptions made, as well as ideas for future directions. This is a really great way trying to build a trust with the model and also trying to improve the model. And so we can gain trust in this model, trying to give us reasonable and good recommendations for different interventions. And then after we did the model calibration and the validation, and then that's the fun part. If you recall, we do have area for improvement to decrease ED wait times. Adri has walked you through about all the plausible contributing factors to emergency department. And the question Adri has asked
in the earlier slides, it is what are the root causes long waits in Saskatchewan hospital. We know all of them are plausible contributing factors, but we don't know it's the magnitude of its impact on ED waits. So given limited resources, so how can we, trying to allocate resources more efficiently? So that's exactly the question our modeling is trying to help answer. So in the next few slides, we will demonstrate with you 3 what-ifs. First of all, what if we can reduce potentially avoidable ED visits for family practice-sensitive conditions during evening hours by 50%? What will be the impact on ED waits? So if you recall, family practice-sensitive conditions are ED or urgent care center visits for health conditions that may be appropriately managed at a family physician office. So, and then we want to ask, say, what if we can implement high-quality care transition to safely transfer the patients to the appropriate care setting, and what will be the impact on the ED wait time? So this is actually one of the output factors. And then what if we have more physician coverage in the ED for busy hours, for instance, between 9 a.m. to 12 p.m., so we can have the patient arrival closely matched with our capacity scheduling. So how would this impact the ED wait times? And we actually run a lot of scenarios, and we probably run over 35 scenarios trying to test different hypotheses on the plausible contributing factor to ED. Many of them were built on evidence, as well as our local data. Some of them were built on expert opinions as well. We're really trying to integrate local data, evidence we learned from literature, as well as stakeholder engagement. So here, I will show you a glimpse of the modeling results for Royal University Hospital. So this figure actually shows the simulation outcome on 2 wait time measures. If you recall, we are particularly interested in 2 wait time measures. One is time waiting for an inpatient bed. The other is time waiting for physician initial assessment. If you see the little star there, it is where we hope we can get to. It is we hope that no one will wait in the ED for care. Everyone can get timely access to care. And so if you read this graph, each dot on this graph give you what is the ED wait time looks like if you can implement that intervention successfully. So the first one I'm going to highlight on this graph is the no intervention. It is the current state. So this is where we are at right now. So time wait for physician initial assessment, 90th percentile is roughly 130 minutes. Time wait for inpatient bed is roughly 26 hours. And however, if we are able to reduce ED visits for family practice sensitive condition during evening hours by 50%, we see a slightly reduction in time wait for physician initial assessment, but not the time wait for inpatient bed. So although, say, we do statistical tests on the results, it is actually statistically significant, but that doesn't mean it is actually clinically important. And then the next what if I mentioned is about the high quality care transition. It's really trying to smooth the transition from acute care to a subacute care setting or even patient's home. So if we're able to improve the efficiency in acute care, and which actually this intervention have the potential to reduce length of stay as well as readmission rate, we actually can achieve quite significant reduction in both wait measures. And then we have another what-if question about ALC hospital days. And what if we are able to reduce ALC hospital days? We also can see significant reduction in both two wait measures. And that did indicate ALC is one of the very important contributing factor to ED waits in Royal University Hospital. At last, if you remember, we do have another scenario regarding adding physician coverage in ED. So if we can have our capacity scheduling, close match with the patient's arrival to have that demand matched with the supply, we actually can achieve the biggest reduction in time wait for physician initial assessment. So that did indicate there's opportunity for improvement in physician scheduling in emergency department. So
So given all these results, so we actually have run many simulation results. We don't have the time to share with you all of that. But in general, in response to the results of our model findings, the ED Waste Initiative validates its assumption of the root cause of ED wait time in local context, and we understand the downstream, which is the output, is a bigger contributing factor to ED waste. And the recommendation based on the modeling results were provided to inform allocation of resources to reduce ED wait times. And one thing I do want to mention, we only show you the results for Royal University Hospital. It's actually, every hospital is a little bit different, so there won't be one size fits for all. So the magnitude of impact for each intervention on another hospital can be quite different from what we see here for Royal University Hospital. So we do need to consider the heterogeneity in those hospitals when considering implementing intervention. Now I will hand it to Adri to share with us a little bit about the lessons learned and the next steps. Thanks, Yuan. So if we take a step back and think about how we've used modeling within the context of the emergency department waits and patient flows work, what we really learned is we need to use the right tools to help us with strategic planning, and modeling is certainly one key aspect, which can't happen without working tirelessly with our system partners to really thoughtfully choose where to focus and invest our time and energy. You're likely curious about where we're going next. So as Yuan showed in the modeling results, high-quality care transitions was a piece of the puzzle that really showed quite strong results. And so what we recognized very quickly was high-quality care transitions are a series of processes around discharge planning, medication reconciliation, advanced care planning, et cetera, and others. And those processes can't happen without teams doing that, both in the hospital and in the community. And so the strategy has really focused now on connected team-based care, both in hospital and community, and high-quality care transitions between. The beauty of this strategy is also that we can impact some of the hospital-specific elements that will improve flow within the emergency department, as well as the community-specific elements and the high-quality care transitions in between. The way that we're supporting this work is to create some space for sharing and learning around what's working in developing these connected teams within community and within hospital, what's working in trialing and testing some of these high-quality care transitions in between those. And for those folks who are living and breathing, working in the Saskatchewan healthcare system, you know that there's a lot of big things happening provincially, and so we're focusing quite a bit of effort as well to align our current work within the flow strategy with provincial health region amalgamation, for example. There's work around physician, different models of physician structures, and so we are aligning with quite a bit of provincial work as well. So with that, I'm going to turn it back to Yuan to take it back one step higher and talk about other applications and future opportunities for modeling. Yeah, thank you. So you actually already see a case study of using simulation model to understand the hospital scheduling and organization and patient flow. So there's actually a broader application of simulation models in the healthcare context. For instance, trying to simulate the infection and the communicable disease spread, and you actually can understand the trade-off between different policies trying to prevent communicable disease spreading. And it also can be used to understand screening programs. For instance, we can use simulation model to test whether having a lung cancer screening program in Saskatchewan going to be cost-effective or not. And it also can help you understand the cause of illness and economic evaluation. So there's actually a lot of research has been done in healthcare in using health system modeling. And thank you. Yeah. So just to close, if you have questions about modeling specifically, Yuan is your gal. If you have questions about patient flow, you can certainly direct them to me. And we're fortunate enough to have Graham Fast, the lead of the ED Waste and Patient Flow, in the room here today, who can also help answer questions about the initiative.
Okay, thank you very much, Adrienne and Yuan. That was a wonderful presentation, and I'm sure we'll we'll get some questions going. We had at least one question come in over the chat, and look forward to further questions. I guess we'll start off with the question that our Edwards has submitted, which was, when you're doing modeling, how do you know what all the relevant variables are when you're creating your model? And that's a question for you, Anne.
I think my answer to that question is, I think virtually speaking, you have all the variables you can control. We do understand we have limited understanding of the current system, so if we are really trying to do the model, I would probably won't say we know all the variables we know. There's definitely something unknown, and even with use of the simulation model, there's also uncertainty within the model, so that's really, we need to understand how the uncertainty, especially the unknowns, which might, impact the outcome of modeling. So so what model project is only give you the outcome anticipated based on what you know about the system. So that will be my answer to your question. Thank you.
That kind of goes back to your quote of statistician George Box. All models are wrong, some are useful. Yeah. And really how useful they are depends on how much information you have to put into them. So we have a question here from Jennifer Graham from Health Improvement Scotland. And welcome, Jennifer. We're glad you were able to join us. So Jennifer asks, as part of the stakeholder engagement, were any measures developed or amended in response to patient, family, or care feedback? So what was the engagement of patients and families in the development of the measures for the initiative?
Mm-hmm. Excellent question, Jennifer. As part of the process of cross-functional planning, patients and families, we had specific patients and families involved throughout the process, so it wasn't something that we took to them after the fact. They were actively involved in the process of cross-functional planning, looking at some of the potential pilots that we wanted to run through the model, provided us some input on which ones we should look at first, second, or third, or what other questions they had as well that we wanted to be able to run through the model. So their involvement was throughout the whole process of cross-functional planning. So I hope that helps answer your question.
Good. Okay, so we're just going to...
The conference is no longer in lecture mode.
Okay, so we've just modified the line now so that people can, if they have questions that you want to speak over the phone line, then the phone line is now open, and you can hit *6 and open your line so that you can ask your question. Has you Ann did her best to hide the math. Hopefully we haven't scared you off. While we're waiting for people to think or maybe come up with some questions they want to ask, just going back to our Edwards question here. Sorry, I don't know what the R stands for. But getting back to the issue of variables in the model and things you know and things you don't know. The comment here is that how you understand the biggest bang for your buck, what the intervention that will make the biggest difference depends on, whether you understand enough about the problem, right? Whether you've got the right variables and the right theory involved. And one piece that they raise is that patients' housing status, so that ability to be stably housed in the community might be a big contributor to the need to go to ED and ultimately end up in the hospital and so on. So was there any opportunity to engage with those types of variables, that type of data in this modeling?
Yeah, thank you for the question. I think the model has a lot of potential to incorporate, multiple factors. And for instance, when you mentioned about the patient's housing status, for instance, I see that maybe as one of the determinants of why people use emergency department. Right now, I think we are really focused on operation processes. We didn't really, zoom into the patient characteristics to look at how patient made the decision to use ED. What are those determinants? What are those determinants that we can intervene so that we can, in a way to either have another intervention, really trying to modify those risk factors to make people use ED more appropriately as one of the examples. So there's definitely potential, but I mean, it's still built on what we know about it, especially from the evidence perspective, and also plus the local data perspective. I mean, given Saskatchewan hospital might be slightly different than what we learn from other jurisdictions. So those also need to be taken into account. Thank you.
Great. Thanks, Yuan. So basically, working with the patients who are coming to ED, to the emergency departments and being in the hospital, what are the interventions we can do with that population? And then, other considerations for future might be, how do we actually change the population of who's using emergencies? Okay. Question here from, disappeared. Just get back to the question. So question here, were there any interesting learnings around how long it might take to see a change have an impact on the outcomes? So, as you model these things and you model the different interventions, were you able to do any sort of an estimation of, what might be a realistic time frame over which the intervention would take effect, and how long would it take to see change?
That's a great question. So in order to trying to take into account the implementation, and in our model we do have variable trying to capture that implementation phase. We do have a ramp-up period for each of the interventions. So basically, as a modeler, I won't say how long this intervention gonna, run fully. So I will leave it for either experts as well as stakeholders trying to say, what do you think the ramp-up period, or what we learn from the evidence, trying to use that as one of the model inputs, and see, given different ramp-up periods for each intervention, how likely we are able to have the outcome we anticipated or we want to achieve. So there's actually definitely room in the model trying to take into account that factor. But regarding how long does it really take, and that's really in the hands of either evidence or decision maker. Thank you.
So any further questions online, or people want to unmute their phone and speak a question?
My name's Will. I'm from Vancouver Island in BC. Can you guys hear me?
Yes, go ahead.
I'd asked a question about actually implementing the results, and if you could speak about some of the successes and challenges there. So if you're trying to target changes in sort of capital space and renovating the space, or changes in staffing, like when we do modeling exercises here, we find that can often be a more challenging exercise than the building the model itself, is getting the uptake and being able to give feasible results that make substantive changes. I'm wondering if you could speak to some of the successes in your region. Thanks.
Okay, so I'll turn it over to Adrienne, and maybe Graham Fass wants to chime in here as well in terms of where they're at with implementation.
Sure, that's a great question, Will, thanks. We just completed the modeling in the fall of this year, and so the strategy has been in development over the winter and spring months, and we're just launching into implementation of the strategy now. So we are developing some measurement framework to understand the success of the work that we're doing, and tracking it as we go, but we are in very much early stages of actually implementing the strategy. And then to your question around some of the hard green costs around renovations and that type of thing, we're fortunate enough to partner with some economic experts in the province here, and are building those types of questions into the model, as well as into a separate economic analysis to try to understand what what some of those the needs are and what the impacts are going to be as we continue to implement this work.
Thanks.
So there may be questions about the specific interventions around what we're doing around connected team-based care. So both in hospital and community. In the presentation, certainly left it fairly high level because the focus is really around how we've used modeling to help us identify the solutions. But if people are curious about what specifically we're doing, there's some targeted work in both Saskatchewan and Regina in hospital around implementation of team-based care through a model called the Accountable Care Unit. That's only one type of model that uses team-based care, but it really is about providing dedicated, co-located physicians on the team with physician co-nurse leadership, and having some very structured and engineered processes around communications for that team as they provide their care. So structured interdisciplinary bedside rounds, for example, nurse-to-nurse shift handovers in the morning are very structured, and the results that we've seen from the ACU that's been implemented in pilots in Regina, and this ACU model has been implemented around the world as well, are quite startling. There's some length of stay reductions, mortality reductions, et cetera, and so that's the specific model in the hospital. In the community, it's taking those concepts of high-functioning connected care teams and how do we support community teams to understand their populations in order to have the right service mix within that team to be able to help pull patients out of the hospital and also provide some upstream services that will keep people from entering the emergency department as well, because often those are the same types of services if we can implement those in the community. So it really is both about team-based care in hospital and community and understanding your population and developing services around those with a high-functioning team. And once you have, and then we are fortunate enough to work also with some keeners in Regina Coppell Health Region who have taken the concept of high-quality care transitions, and they're looking to pilot some of those between the emergency department and their community teams that are starting to set up. So there are some really specific examples of this happening already in Saskatchewan. So we're continuing to monitor and connect with those teams to see what kind of impact they'll have. But again, we're in pretty early stages at this moment. Turn it back to Gary.
Great. So another question specific to the modeling. This will be one for Yuan. So Yuan, is modeling, this type of modeling, is it a form of predictive risk modeling?
I want to say it is that I think the model that which you see in the case study might not be a predictive risk model, but I do know with use of discrete event simulation model, you actually can do predictive risk model. For instance, one example I would give you, it is the other project I'm working on is trying to understand the lung cancer screening in Saskatchewan, whether it to be cost effectiveness. And in that model, I would say it is actually a cancer risk prediction model, and developed by Ontario. I would think that is more predictive risk model. Is really look at the cohorts and trying to test the intervention on that. I think for our patient flow model, it's really process driven, and we didn't really model the heterogeneity or the cohorts or population. We do have some high-level population demographic in there, and but not in really the great detail trying to have all the risk factors, and yeah, not yet. But it definitely should be something interesting to explore. Thank you.
That's kind of going back to that earlier question, where what you're dealing with here is you're trying to model processes for dealing with all comers. Who's coming through the door now, and how would we best deal with them? Okay, any other questions, either through the telephone line or through the chat? All right, well, I think the silence means we've totally satisfied or people are just, their heads are buzzing and don't know where to go next. So I, again, want to thank both you, Anne, and Adrienne, for a wonderful presentation. This is a complicated work, but presented in a way that was makes it easy to understand for the uninitiated and the non-mathematicians among us. So thank you both for the presentation, and I want to thank everyone for participating. Shout out again to Jennifer Graham for dialing in from Scotland, and we had a participant from BC and from all across the province. So thank you again for participating and asking your questions and listening in. Hopefully you found it useful and helpful information. Before you exit, please take a moment to complete the evaluation poll, and we'll look forward to having you back at the next one, which will be now after the summer. So you can look forward to the next QI Power Hour coming up in September. Have a great day, everyone.